All right, so now throughout this, there is some time scheduled at the end for discussion and questions. I do have the chat box up as well, so feel free to kind of post in there if you want, or, you know, totally fine to just holler at me too if you want to ask a couple questions or whatever have you. I think we got a good bit of time for discussion if needed. All right, so we'll start off with a brief pre-workshop survey here. After this, I'll go ahead and set a framework down by discussing disparities and barriers to healthcare services among American Indians and Alaskan Natives. Now, I'm going to abbreviate this AIAN just to make it a little bit easier going throughout this presentation. Following that, I'm going to chat a little bit more about dermatologic conditions among AIAN. Now, for the pre-workout survey that you see here, please go ahead and scan this QR code with any kind of smart device that has a camera. That'll bring you right to the survey just to make it a little bit easier. Actually, let me go ahead and let me see if I can copy this and put it in the chat box as well as an alternative means of accessing that. And we'll take about 2 minutes to take care of this, 2-3 minutes or so, and then we'll move on at that point.
So you've already had this information collected through BingApp, so you don't have to do it again right now.
Okay. All right. Perfect.
Okay. I apologize. This is different. You can continue. Apologize for that.
Okay. Gotcha. Oh, you know what? I guess it was the maybe some of the objectives that was already sort of taken care of. Okay. Yeah. This is a little different.
Thank you.
We're still doing good on time, so I'll let you know when we're getting close. And again, feel free to let me know if anyone needs another moment or so. Wait another 30 seconds or so. Again, feel free to let me know if more time is needed. Okay. All right, everybody set?
Let's have a couple more minutes. Thank you.
Sure, absolutely. Yeah, just checking in one more time. No pressure. We still have a good bit of wiggle room here.
Looks like we're still filling out a few.
Okay, sounds good.
Sorry, we were just saying we're a little slow group here.
No, that's okay. No, I appreciate the consideration of the questions. All right, just another non-pressured check-in here. How are we looking?
Okay, I think we're ready.
Okay, all right, awesome. I appreciate y'all taking the time to do that one for me. Thank you. Okay, so we have three main objectives. This is probably something that we already touched on, right, through that pre-survey to the day's session. But to run through this again, so by the end of this, you should be able to name two health disparities seen among AIAN, describe two specific barriers to healthcare services that AIAN face, and then list and describe the four common dermatologic diseases among AIAN. Okay, so starting with disparities, let's take a second to consider the discussion points listed here. And then, I want to try to make this a little bit more interactive. So I'm interested in hearing if anyone has thoughts on if American Indians and Alaskan Natives have longer, shorter, or similar life expectancies to other groups. And any answer is a good answer. I want to hear what you think.
Shorter. We're all saying shorter in the room here.
Okay.
Six of
Gotcha.
us.
Okay, so we're on the same page with shorter. Let me ask you this. How about chronic diseases? What do you think may affect AIN more?
Diabetes.
Diabetes,
Liver.
okay. I heard something in the background.
Oh, could you hear some?
Yeah, so diabetes is a good one. I may have heard a couple more that were a little muffled, but let's hold on to those thoughts. And then let me throw out one more question here about a prominent cause of mortality among AIN. Any thoughts?
Accidents.
Yeah.
Trauma accidents.
Yeah, that's spot on. So I think we got some really on this topic well-educated folks in the group. So American Indians and Alaskan Natives born today indeed have a life expectancy that is 5.5 years less than the average of other races in the U.S. population. So we're thinking 73 years versus 78.5. So as we touched on as well with the chronic disease, AIN continue to die at higher rates than other Americans in categories including chronic liver disease, diabetes, mellitus, as we discussed, unintentional injuries, that one came up, colorectal cancer, and intentional self-harm and suicide. So, as a quick example here, mortality related to liver disease is about 4 to 1 compared to an average of other groups. And then mortality from accidental injury is about 2.5 to 1. Now, just an interesting thing to note that came up in the literature is on the flip side to all this, pathology from Alzheimer's disease is noted to be lower among AIAN. Okay.
Dr. Duran, in regards to the suicidal, that is probably a higher number for adolescents and younger, right? Or do you know?
So I actually don't know off the top of my head. And I would have to go back to the literature to see if that was even stratified out by age. Unfortunately, to some extent, there's quite a few gaps in the literature among, looking at this specific population. However, I'd like to be able to get back to you on that.
No, that would be great because I know that there's some, definitely some work being done and a lot of emphasis on that. And I know definitely in New Mexico and the Navajo Nation area around there. And I think Dr. Tassie Parker in our Center for Native American Health, there's been quite a bit of, I think they're doing some current studies now. I'm not sure if they're NIH or what, but around suicide in adolescence, I believe.
Okay, for sure.
Yeah, thank you.
And I threw my email address in the chat box. If you could, if you could shoot me an email, that would be great. That way we can establish some correspondence back and forth. Okay, so to review this learning objective, AIAN have lower than average life expectancy, higher rates of several chronic diseases, including diabetes, mellitus, and liver disease, and then higher mortality rates from injury. Okay, So let's shift to consider a few barriers AIAN face when obtaining health services. So the Indian Health Service, which I'll abbreviate IHS in brief, is a division of the United States Department of Health and Human Services. And the IHS offers health services to AIAN members of federally recognized tribes. So, again, painting a little bit of background here, various treaties between the tribal nations and the US government were established that help provide care for AIAN. Now, I would like to ask, again, throw out whatever thoughts you have here. What are two barriers you can think of to AIN getting health services?
Lack of healthcare professionals in the area. There's
Yes. Yeah. Any other thoughts?
well, I don't know if it's all the same, but I mean, transportation is a huge issue, right? I mean, if you just think about the Navajo Nation itself and the dearth of providers, but I mean, where they are, right? Like, so much is in frontier counties, right? And so how do you even get places? But I don't know if that's kind of all the same kind of lack of access in that way or barriers.
So, probably, a little bit different specific examples of the same category as you suggested, right? And that's certainly one of the issues that I want to touch on here. So regarding the IHS, I'll speak to this other barrier. One of the big barriers here is actually in the form of funding, and that's the funding needed to meet the demand of the health services needed. So let me get a little more specific here. About $4.2 billion of annual funding is available to the IHS, but the estimated amount needed is just over 40 billion. Okay, quite a discrepancy there. And then, as we just discussed, that facilities that administer health services are often focused in rural areas, despite larger population centers. That's about 60% of AIAN being in urban settings. Now, it's not to say that there aren't issues, for example, that were just discussed in that may actually be focused in rural areas specifically. But certainly that transport and then the discrepancy of where the majority of some of the health services are available versus the larger population centers exist.
Stefan, there are a few comments in the chat, and you may not be seeing the chat. So one of them is access to care, financial resources, and language. I just wanted you to know.
Perfect. Thank you. And these are all, yes, excellent contributions here. And thank you for pointing that out. Let's see, let me get that a little more in my view here. This chat box. There we go. So, and then, certainly I think as some of the underlying themes that were discussed through some of our presentations, language and, certain word choices and, if you will, emotional intelligence and how we come across are all things that should be considered. And I'm sure that in certain circumstances create barriers. Okay, so any questions right now before we move on to some of the dermatologic conditions? Okay. All right, so we'll switch over to more of the skin stuff. We'll cover 4 cases in total, and that's 4 entities through the means of clinical cases. And you can see here we have actinic prurigo, also called hereditary polymorphic light eruption. We'll chat more about some of this odd wording. Systemic lupus erythematosus, acanthosis nigricans, and acral lentiginous melanoma. So once we read through a case and discussed associated image, I think it sounds like our group is probably small enough that we won't split into breakout rooms. But certainly I would like, again, as we've been doing throughout, some thoughts. I want to hear what you're thinking. And again, every answer is a good answer. We'll take a couple minutes to discuss or so, after a period of essentially independent researcher, if you're in a group, I'm not sure how many folks are in person, you can discuss amongst yourselves to try to come up with some of the answers that I'll pose about these cases. Okay. Now, I do want to mention the goal here is to increase awareness of the conditions. We can't necessarily comprehensively go through all this. It is a little bit out of the scope when we're getting in detail about parts of the evaluation and treatment and so on, but we will, in a superficial sense, talk about some of those things. All right, so please take a second to read this case to yourself, and then we'll take I'll ask that you take a couple minutes. Oh, I'm sorry, let me let you read that case, and then I'll chat about the associated image. I'll give you a minute there. Okay, everyone doing all right? Okay, I'm gonna go ahead and move on to the next slide here. Let me know if you need an extra moment. So the associated image for case 1, here you see the scaly red plaques. So these are raised, and you see it mostly in the center of the face here with very subtle sparing around the nose and a little bit just below the lip here. This is what we would refer to as sort of a sun-exposed or photo-distributed area. And as you can imagine, because often the face, maybe pre-COVID or soon to be, is not covered up as frequently, right, as other body areas. Okay, so at this point, let's take a couple minutes, about 2 minutes or so, just to consider some of the questions that you see here on this slide. Again, feel free to, you can do a little bit of Google searching or discuss amongst yourselves. About another minute. All right.
What's the name of the photosensitivity, the hereditary photosensitive something Perigo? I'm thinking that, but I'm also thinking just because of age, gender, lupus as well with this photosensitive rash, but she's otherwise healthy, so that probably wouldn't be as high up on the list. I would also, it wasn't one of the ones that we mentioned, and she doesn't necessarily have scales, but I would also think psoriasis because extension surfaces.
Yeah, excellent. So very good thoughts. And you're right on track with that differential there. Let me ask, and then before I kind of pop to, more discussion about the answers here, any thoughts on, barriers that might exist in this scenario based off of what we already discussed?
I think a major barrier would be, I feel like access to care is just a barrier in general, but also to subspecialty care. So being able to see a dermatologist. I know, like from my personal life, my sister has eczema, and our PCP was giving her antifungals for 3 years because we didn't have a dermatologist. So I would say just access to subspecialty care might be an issue.
Yeah, so very good thoughts. Just as you said, so the access, that came up before too. Transportation issues, for example, access to specialty care. And there are, for example, in many, many places across the nation, very high wait times and, a low amount of, for example, dermatology specialists. So, and that's where, I hope to get across here just a little more idea of some of these different conditions. That way primary care can kind of keep that in mind, and some of these differentials. So I think you're spot on there. Let me pop over to some of the answers here. So, exactly like we heard, actinic prurigo, and that's essentially actinic referring to light or photo, and then prurigo referring to itch. So that other term was hereditary polymorphous light eruption. So hereditary referring to the genetic component. We talked about light, and then polymorphous meaning that this can present in sometimes different manners of how it looks on the skin. All right, so this particular condition, actinic prurigo, has been identified in different, particularly among those of AIN descent. So in brief, this entity represents an inflammatory reaction in the skin to UV radiation from sunlight. And more specifically, that is the damage to that cell sustained from the sunlight and the immune system kind of picking that up and not being too happy with it. So it is reported in an autosomal dominant inheritance, and up to 3/4 of the individuals studied report a positive family history. So while specific genetic associations are suggested in other ethnic groups, data is actually lacking pertaining to specific genetic parts of the DNA associations for AIAN. So I did kind of mention that earlier, sort of a paucity of research, if you will, among AIAN. So the condition is more common in young females. I think we heard that in the individual that commented on this, right? So that was spot on. This may persist into adulthood. Frequency, again, is higher among the indigenous of North, Central, and South America. Findings include those red or erythematous papules and nodules. So those are bumps on the skin of different sizes. Sometimes with eczematous-like features, meaning it's kind of dry and scaly looking. Over time, it can become lichenified, which just means essentially the skin is thickening up from constant irritation. So the skin findings are in sun-exposed areas. Parts of, for example, the eye, the conjunctivitis, so the sort of more moist parts of the eye, if you will, and then inner parts of the lips, which is referred to as cheilitis, can also be seen, and those are more common features. So, and I think it's important to hear, so one thing to always keep in mind is sort of background clinical I guess, physicianship, if you will, is the discussion of heritage with a patient and how this may pertain to delivering patient care must be considered and assessed in the appropriate clinical setting. So that's always, something you got to keep in the back of your mind to reach into the toolbox of having that discussion if you think it may be pertinent. And in a case like this, if you suspect this condition, it may be valuable to evaluate sort of the heritage, if you will. So differential, as we chatted about, eczema, psoriasis certainly can be scaly and red. Other sun-induced skin conditions like lupus, but again, as was so astutely pointed out, this person isn't really that sick, maybe a little bit on the younger side, so those things would point against lupus, right? Treatment in a basic sense involves sun protection, sunscreen, barriers, clothing, staying out of the sun during peak times. And then there are various types of topical and body-wide or systemic treatments for this. All right, let's pop to case 2. Please take a second just to read through this yourself, okay? Okay, just holler at me if you need a little bit more time, otherwise I'm going to move on here. All right, so this image is associated with case 2. We see this sort of thickening of the skin right here, and you can compare that to more normal skin just down here in the bottom left of this image. Almost has a velvety appearance, and notice compared to this skin down here that it's a bit darker as well. And we are in a fold, what we would refer to as a flexural area, sort of a skin fold, if you will, the inner parts of the elbow, in the underarms, for example. Okay. And then I'll ask the same thing. So, as we go through these cases, pretty similar structure. Please take about 2 minutes to consider some of the, what this could be, some of the epidemiology associated, so on and so forth. And you're very welcome to toss stuff in the chat box too about different thoughts. That works as well.
Oh yeah, both of you. I feel like acanthosis nigricans, we all know that it's kind of associated with type 2 diabetes, although it's most commonly seen in older individuals, I'd say 30s, 40s, male. I think it's male predominant, but it's more so, it's like a lifestyle disease. So it's more so seen in like overweight, obese individuals, and more common in Black, brown, like Latinx communities. That being said, in these communities, you also see a higher prevalence of type 2 diabetes, hypercholesteremia, these type of lifestyle diseases in children, especially if like the child has a BMI in the 95th percentile. So it's quite common in children as well. But yeah. So
that's perfect. I think I can move on to the next case. No, that's exactly right. So, as you said, typically, what I'll use a particular word choice here, historically thought of as being more so adult onset, but as time changes, certainly, again, and you said this, very much more prevalent in younger populations and pediatric patients.
Unfortunately, I think that point is well taken because, again, to your point, older adults, but as we all know, in the last many years, the rampant increase in obesity in adolescents, right, not only, and certainly more prevalent in certain racial, ethnic groups, but that, I mean, has really changed it. I mean, we see that in our adolescent clinic all the time, you know, with our young kids, unfortunately, now, which used to be, again, as you said, Joanne, an older person, you know, in age. Yeah.
Right. Absolutely. And, you know, certainly, I think to some extent, you know, that idea is certainly very prevalent, but it is important to focus on that, you know, all this sort of metabolic syndrome, if you will, very much prevalent in the younger population. So, you know, as was pointed out here, and I'll run through, I'm a big fan of repetition. I think that helps really clarify points and helps with memorizations here. So acanthosis nigricans, I'll abbreviate that AN. So this is based off of data that is available. So, you know, certainly one can make inferences off of data. You have to be careful to, but also to make specific discussion, it can only be based off of what, you know, studies showed. So the specific tribes, you know, I'll speak about here were those that were studied. So those in Nebraska, South Dakota, Texas, particularly demonstrated, as we discussed, elevated prevalence of AN compared to other ethnicities. So specifically, that was pointed out in some of the research that's available, is that AN among children of the Winnebago Omaha Indians was about 19%, and we're talking prevalence, compared to about 13% in African American children in this particular study. Also cited were those among Cherokee children of the Cherokee Nation and adults. Rates were as high as 34%. Okay, and that was reported in that particular study. There was a 2010 study that reported rates of approximately 6.8% for other combined ethnicities of similar age groups. So I throw that in there for sort of a reference to try to compare those numbers. You know, we talked about that increase in childhood, that prevalence. So as we discussed for the image associated, we commonly see in the folds, you know, flexural areas, if you will. So folds of the elbows or even, and it tends to be more of an upper body predominant condition, but you can see it moving down the extremities. You can see it on the sides of the neck, related to the underarms. Frequently a family history. You might see diabetes as something that runs in the family. So we chatted about that association there and the association with what we refer to as metabolic syndrome, which could include other derangements and things like blood lipids or blood fats. For that reason, let's say you happen to see or diagnose acanthosis nigricans in you know, a youngster or even an adult patient, you may consider doing screening for diabetes if that has not already been done. Now, treatment here is, you know, aimed at the underlying condition that can be driving this. Again, workup for metabolic syndrome, you know, blood glucose management, lipids or blood fats would be, you know, pertinent, and then trying to target that would be essentially effective treatment. So the differential, this is a pretty, I would say, I don't want to say easy to diagnose, but when you see these velvety plaques, there aren't too many other things that would pop up in the differential that would be in these areas. Things that would come up, like psoriasis, for example, tend to be, you know, very symptomatic, a little bit more red and inflamed. So, you know, in the absence of that, the diagnosis really does fall right into acanthosis nigricans, and there aren't too many other things that would really mimic that. Okay. Let's pop to, and I, you know, certainly appreciate, I see that comment there. Thank you very much. So case 3, please take about 1 minute, 30 seconds to a minute to read through this. And again, stop me if anyone needs another moment. I'm going to go ahead and move on to our image associated with case 3. Okay, so while it is difficult to see what part of the body we're on here, I draw your attention to what I refer to as the morphology of this rash. So scaly, some of these are round, a little bit clearing in the center. We refer to that as annular. This, as you can imagine, if you rubbed your finger across this, there would be texture to it. So it's raised up. Therefore, I call it a plaque because it's quite large. And these smaller spots you could call a papule, which just designates a smaller raised spot. I want to draw your attention to this, the border here that's a bit red. Okay, so that's an indicator of inflammation in the skin. Same format we're shooting for. And I realize we have a limited number of entities that we're chatting about. So there is, of course, process of elimination. But again, through repetition, we'll drive the points home. So take about 2 minutes or so. Feel free to discuss amongst yourselves if I think for our in-person group, and otherwise a little bit of Google searching.
And speak on this a little bit. I think my colleague, Joanna, so probably most likely lupus. It's seen in the age group like 20s to 30s as common this patient presentation, often seen in female gender. For ethnic groups, I might be mistaken on this, but I believe it's in Black and Hispanic. I'm not entirely sure, actually. I don't want to speak on that. It might be incorrect. But something that we saw in the image that you showed, I believe, was describing as that's something that would be associated with lupus. And correct me if I'm wrong on that.
Yeah, that's right.
I'm not sure.
I believe I know for sure it's African American. I'm not as certain on that index, but African American and AAN, I believe, are the two with most prevalent groups for SLE.
Yeah, so again, there's just a little bit of in and out on some of that, but so far everything I heard is spot on. I agree with all those things. And again, like I said, I'm a fan of repetition here. Let me run through all these points. So very much on the right track. Let me say, so, research on systemic, and I point out, so systemic meaning body-wide, including the organs, lupus erythematosus, and that's SLE, and cutaneous lupus, which cutaneous referring to the skin, limited to the skin, using the IHS data that is available, as well as studies of specific tribes, such as the Cree, indicate that the prevalence and the incidence of SLE may be comparable to that of African American patients, right? Those that are thought to have the highest incidence and prevalence. So, translation there, and I choose my wording carefully with how I present that, because data and making claims are based off of being able often to have a high quality study, but also an abundance of that can be relatively reproduced. And so the important takeaway here is, if you're dealing with folks that are of AIA and heritage, you need to keep this a little bit maybe higher in the differential if you're seeing this morphology that could represent skin lupus, right? And that's because we know there's a higher incidence and prevalence based off the data that's available. So a couple interesting things that we're seeing in some of the research that's available. So one report suggested genetic factors may influence clinical expression seen in SLE with vasculitis. So that's involvement of the blood vessels, significantly more likely at the time of diagnosis and during the disease course. And this is among AIAN. So, I'll say in another study, increased genetic American Indian lineage was thought to be protective for certain factors, including oral ulcers, so ulcers in the mouth, photosensitivity, so that's the worsening of the rash related to light exposure, and then a certain type of skin lupus called discoid lupus. So again, those entities I just mentioned may having that sort of lineage, if you will, among AIN may be protective. All right. So what does that mean clinically for us? I think the thing to keep in mind there is the presentation may be a little bit different than we see in other groups. So it's important to have a high level of suspicion if you're working with known folks of the AIN cohort. So I do want to mention that while the specific classification of cutaneous lupus is a little bit beyond the scope of this workshop, I will say that, again, some of the data through the IHS, the lupus registry, identified that a malar rash, and that's that sort of red rash with quick onset in the center of the face, is in approximately 32% of individuals was identified, okay? So that's one thing that has a little bit higher chance of being essentially a presentation of lupus, so among the AIN cohort. Okay. Now, you know, again, I think we mentioned this a little bit with the actinic prurigo case. Something like lupus would be on the differential. That was, you know, excellently pointed out. Actinic prurigo, we may think a little bit younger patients. Lupus may be a little bit older. So instead of the teen years, we're thinking 20s and 30s or so. That was pointed out with this case. Folks tend to be often a little bit more sick in times of presentation. Again, female predominance. Okay. So, and, you know, actinic prurigo, again, there are a lot of different entities that can be related to sun exposure. You know, so those would be on the differential for this. We did point out, we did discuss the differences between actinic prurigo, that's case 1, versus systemic lupus erythematosus and its cutaneous, the skin involvement. Probably some of the other entities are more, you know, again, beyond the scope of this discussion. Now, treatment does become a little bit complicated based off of different labs that are done and the workup that is done with somebody with suspected and or confirmed lupus. But generally speaking, again, we're talking about sun protection, absolutely important. There are, you know, if we're limited to the skin, for example, and the severity is not very high, we may just do topical treatment. Otherwise, we're starting to think about medications by mouth, and that's for more significant involvement of the skin, and if there are internal organ involvement as well. Okay, any questions so far? Okay, let's go ahead and move on to case 4. You know the routine. Please take a second to read through this. Go ahead and pop forward here to the image associated with this case. If anyone needs a moment, just let me know. Okay. So we can see the bottom of the foot here referred to as the plantar aspect. We know we're on the forefoot if we divide, so that would be the portion of the foot split into thirds that is closest to the toes here. And then, you know, the sort of elephant in the room, if you will, is this black nodule that is associated with the forefoot. Any thoughts here? Same routine. Please take about a couple minutes to do a quick bit of research or discussion amongst yourselves, and then we'll come together and chat about this. It will take just a little bit more time, another 30 to 60 seconds, and then we'll chat. Okay. Any thoughts on this one? Again, all answers are good answers.
Hello.
Oh, hey there. I heard somebody.
It's Joanna again. Sorry for like having the presentation. We were actually discussing here in person. We're talking about this is a melanoma, like specifically lentiginous melanoma, which tends to be the black spots under the foot. I don't believe there's a gender discrepancy. I think it turns to it adults most often, and it's most common in
So, I may have lost you there.
We're losing connectivity here a little bit. Sorry.
No, that's
Pop back on here in a second.
okay. That's quite all right. So it was a little bit choppy too. So let me pop over and then we'll just run through this all together. So I did hear the very first part, spot on with the diagnosis. We're thinking melanoma here. So in general, rates of melanoma are thought to be lower in AIAN compared to Caucasians. However, and this is the sort of differentiator you got to pay attention here too. The stage of presentation is thought to be higher. So lower rates overall, but when these folks are diagnosed, it's advanced, okay? Which usually we're talking about a poorer or a worse prognosis, right? So while one study reported AIAN predilection for acral lentiginous melanoma, and that's referring to often we think about the hands and the feet, other data reports superficial spreading, that's a different form of melanoma, as the predominant type. However, in that study, about 50% or more of these cases, when looked under the microscope, were recorded as not otherwise specified. What I'm getting at here is that there is basically a hole in the data that is specific to AIAN. The study that was done here was not, didn't stratify and label all of these types of melanoma accordingly, so it's hard to draw a great conclusion from that. But, again, what we know is that when this does present, it's usually later stage. What does that mean for us clinically? Look at the hands and the feet. Somebody has, you're doing a skin exam or whatever have you, somebody has socks on or whatever, take the second to pull the socks off. Take a second to look between the toes. You might find something that could save somebody's life, Now, among males and females, rates of melanoma are about equal. Mean age of diagnosis, interestingly, is lowest among AIN at 52 years compared to 59 years of age in African Americans and 57 years of age in Caucasians. Again, the big issue, though, is we don't have a great deal of data here. Differential diagnosis here, we're thinking about other skin malignancies. There can be bruising that can be very dark and in fact look somewhat like melanoma. There can also be benign tumors of the blood vessels that can mimic this. Ultimately though, paying attention to it and making sure it's addressed is the thing that is important, and not just disregarding a spot that looks like our image. So treatment would often be surgical and could involve chemotherapy, so it's body-wide treatment as well. Now, I would like to take a moment to discuss skin pigmentation among AIAN. So I'll primarily frame the topic here using what's called a Fitzpatrick skin type scale, which is a representation of how readily someone is able to tan, not necessarily their baseline skin pigment, all right? So that's the big differentiator there. The scale is on a one numerical, it's from 1 to 6, with 6 indicating an easier ability to tan. Now, regarding the Fitzpatrick scale, as with other races, there is a wide range of skin types among those in the AIAN group, as well as a wide range of baseline pigmentation among American Indians and Alaskan Natives. So this is a reflection of mixed races as well as regionally variable genetics and environmental factors. Okay. In one study where the Fitzpatrick skin type scale was self-assigned among folks that were in the study, nearly 83% of non-racially mixed AIN respondents categorized themselves as type 4 or above. And again, that's on a 1 through 6 scale, with 6 indicating that folks are able to tan more quickly or more readily. Among those 3 Fitzpatrick types, again, that's 4, 5, and 6 that we were just referring to, about 63% designated themselves as type 4 and 5. Okay, so again, takeaway point there is that you can't just assume based off of what you're seeing that somebody is part of a group or not, or a certain lineage or heritage. It's often important just to keep in mind, very, appropriately phrased discussion objectively. Does that make sense? Okay, any questions so far? Okay, so let me, this is the post-module survey, same scenario here. Please take a few minutes just to take care of this. And then I have one more, essentially just some closing comments and discussion points after this. That way we have a bit of time to chat. Sound good? See if I can. I'm trying to, may have paused things here. I don't know. Can everybody see the screen there?
You can see it.
Okay, excellent. Well, let's take a few minutes to run through this, and then we'll come back together for some closing points. So let me try to get the link. Let me try to put this link into the chat box here. There we go. And we're still good on time, our allotted time, so no rush. All right. Anybody need more time?
We're good over here.
Excellent. Excellent. So, one point that I touched on earlier that I want to address again is that research focusing on AIN overall is lacking in many different areas. So that's true particularly for dermatologic conditions. So, certainly please think about, doing a little bit of research in this area, trying to push things forward. Every bit of knowledge is good knowledge. So interestingly, even sometimes quote unquote negative studies regarding clinical trials and things of that nature with therapeutics can be very, very helpful. So that is my appeal there. Any questions, thoughts, feedback for me?
Hey, Dr. Duran.
Yep.
Excellent presentation. I learned a lot. And thank you so much for your presentation at this point. I think Dr. Garcia's on call and knows that Medid Portal and many schools are struggling with content related to Native American, Alaskan Indian content. So this is very important and past due. I think that the good things that you have, the strong elements, right? So I'm putting on my associate Medid Portal hat. I think the strong elements that you have is when, it is a topic of urgency and interest, and it's accessible for all schools.
I think I just lost you here at the end, about 10 seconds ago. Still with me?
Can you hear me now?
Yes.
Yeah. Sorry. Let me see if I could turn up the volume.
It did blank out for probably 15 seconds or so.
Oh, okay. Great. So I think two, what's really good as well is the reflection, having people answer questions ahead of time and then repeat those same questions at the end. The case discussions are vital. I think, so those are all necessary for a Medid Portal submission. I think that what you still need to do that's important, because you touch upon it, you touch upon two important components, but they need to be fleshed out through your module. And the two components are one, really describing more so these conditions across tribal nations or communities.
Yeah.
Even if we don't have that data, I still think you need to talk about how these four conditions exist, whether it's in the Cherokee Nation or the Navajo, or give some slides on that and more discussion. Oh, sorry. I have my chin up against the screen. Okay, I'm used to sitting very close to the screen.
Oh, that's a yeah.
And so definitely I want you to give that thought, because as you're talking about incidence and prevalence, two things are coming to mind. Like one, you should have more slides that show the difference in incidence or prevalence between Native American communities and other communities.
Okay.
So that needs to be on the PowerPoint. It can't just be in the facilitator guide. It needs to be in both places.
Okay.
And then even with incidence and prevalence, you have to give some thought of how that exists within the very, because I think there's how many tribal nations across the country?
Gosh, I think Dr. Garcia probably would
Over 600.
Over 600. So that, there has to be some consideration or balance between, you can't do 600 comparisons, and I don't know if that data exists, but you're going to have to show those two things, right? How the Native American AI community compares against African Americans, Hispanics, Asian, white, and then also give some description within the Native American Alaska Native community. Yeah. The second thing is, and Andrea did this very well, you talk about social determinants of health and culture, but you don't really include that in your discussion of the cases.
Okay.
So your case descriptions have the opportunity to do that deep dive. You say, like, this one person's in rural New Mexico, they're part of a tribal nation, they're constantly working outside.
Yes.
Which also brings up the question of, yeah, you could tell a person to stop being in the sun, but maybe then they don't have a job. And if they don't have a job, they can't support themselves and their family. And so I think that with your 4 cases, you do the right thing by talking about clinical presentation and the underlying genetics or factors, but you don't talk about you don't really address the social determinants of health, of how it worsens their condition or how it might impede effective treatment.
Okay.
And so you have to do that. You really have to consider how social determinants of health will affect diagnosis, treatment, prevention.
Perfect.
Through a cultural lens, and frame it in a way that you don't want this case to represent everyone of Cherokee identity,
right? But
you do want to say that, this higher prevalence may be due to these reasons.
Okay.
So, so that's that inclusion of the social determinants of health, but also the cultural determinants of health, which is really the nature of this module, right? It can't only be treatment, what it looks like, gender distribution, age distribution. And then at the end, you should add a summary slide comparing the 4, because I think that's going to be important. In hearing you speak, I know you know all this because I could tell when you elaborate on certain things, but that needs to be consistent and thorough and on the slides themselves, because most of your learners are going to have no appreciation of this. And so some of us are visual learners, so we literally have to see it up there. So I think if you do that, and Andrea's module does that very well, if you do that, it's going to get in.
Okay.
The absence of that, you're going to get a lot of questions from reviewers asking you to expand upon it. So you might as well be proactive and take care of it, so it reduces going back and forth. But excellent work. I'm so happy that you presented and you brought this to us, and we've all got a chance to learn from you. So thank you.
Well, you're very welcome, and I appreciate the opportunity to do so very much. And certainly my, advisors. It's a long course so far, a lot of fine tuning. There's a lot of people working together to put this, to get this important information out there. So, shout out to them. A big thank you.
Yeah, thank you, Dr. Duran. I would echo everything Dr. Sanchez said in my little online assessment that you just did. I basically just pretty much said the same, although Dr. Sanchez elaborated more and just asked if you could have the data on the slides and other pertinent information, basically like that summary one. But I think the data is important because you spoke a lot about it, but I couldn't keep things straight or would want to go back to that and see that later.
Perfect.
Yeah, so thank you though. It was fun and informative. So thank you.
Excellent. Thank you for your feedback.
Yeah, excellent.
Okay. Well, again, I do very much appreciate it. If anyone has not, please help me out with this post-module survey. This, frankly, we need a good sample size to try to get some meaningful statistics on how to improve this. So if you have not, please help me out here. Thank you. All right, folks, I'll leave this up just for another minute or so. I think we're at 4:01. We're at our time. So thank you again.